Hi everyone, welcome to researchmd.com. Another great presentation today. We're going to teach you everything about renal stones under 9 minutes, okay? Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis, and I'm also a director of research. Since we don't have much time, we have to do this under 9 minutes. I'm going to do pretty fast, okay? So what are the renal stones? They're hard deposit of minerals and salts anywhere from the kidney to the urogenital tract, renal pelvis, urethra. Could be any of those places, okay? Epidemiology, male more. Peak incidence 45 to 70 years. Prevalence like 1 to 20%. Now, nice picture, kind of clearly says 75% calcium oxalate stones, okay? Most common stones is calcium oxalate, remember. Least is calcium phosphate. Everything is good to know, like what's the most common. So calcium oxalate stones, if you want to remember something, very, very important, 75% is calcium oxalate stones, okay? And the pain and the clinical features kind of depends upon where exactly the stone is. We're going to come back to that later. And then if there's small kidney stones, like if it's asymptomatic, don't worry about it. And the classic pain, what is it? Pain radiating to the groin, lower abdomen, labia, testicles, okay? And you got like costovertebral tenderness. And those are the main. Then you can have hematuria, nausea, vomiting, dysuria, frequency, urgency of urine, passage of stone, patient unable to sit still because of the severity of the pain. Okay, now let's look at the relationship of the location of the stone and the pain and the symptoms. Okay, kidney, if it is in the kidney, vague flank pain, hematuria, proximal ureter, you can have renal colic, flank pain, upper abdominal pain. You got the middle section of the ureter, you can have renal colic, anterior abdominal pain, and the flank pain. And the distal ureter, you can have renal colic, dysuria, urinary frequency, anterior abdominal pain, and flank pain. So it's good to know, like it depends upon where the location of the stone and the symptoms presentation is slightly different, okay? Now, let's look at the different types of stones. First, we're going to talk about the calcium oxalate stone. We already said 75%. Causes hypercalciuria, hyperoxaluria, hypocytraturia, can result from increased intake of ethylene glycol, vitamin C associated with inflammatory bowel disease. So if I'm writing an examination question, what am I going to write is like somebody come with ethylene glycol poisoning. They're going to have like oxalic acid and oxalate crystals and the kidney failure. Good question, right? And if I'm writing a question about inflammatory bowel disease, so I'm going to write about calcium oxalate stone. So two major points, remember. And the precipitate also decrease urine pH, it precipitate crystal. Look at the it's biconcave dumbbells and the bipyramidal envelope and radio opaque. Remember, calcium oxalate, you have to know because 75% of the stone calcium oxalate. Uric acid stones, gout, hyperuricemia, hyperuricosuria, and again, if I'm writing a question, we kind of talk about somebody having leukemia, undergoing chemotherapy, and that way we can write. And the precipitate, there is decrease in acidic environment, okay? Crystal appearance, reduced rhomboid, rosette, needle shape, and remember, it's radiolucent. That means everybody should know the difference between radio opaque, right? Radio opaque means you'll be able to pick it up from the X-ray. Radiolucent is not very clear. And now struvite stone, this is like, again, UTI with the Proteus mirabilis. Again, the question, if I'm writing an examination question, focus on the Proteus mirabilis, okay? And the precipitate in the increased urine pH, and look at the shape. So you got like a rectangular prism, coffin-lid appearance of the struvite stones, and weakly radio opaque. And the calcium phosphate stone, you can usually see in hyperparathyroidism. The examination question is going to be about hyperparathyroidism, and then you got type 1 renal tubular acidosis, and the precipitate in increased urine pH in the alkaline, and the crystal appearance in the wedge-shaped prisms, and these are radio opaque. Now, then you have cystine stones. Where do they have? Like cystinuria, which is hereditary, and it's an autosomal recessive disorder, right? The defective intestinal or renal tubular transport of the dibasic amino acid aciduria, cystine accumulation, and the precipitation is like decreased urine pH. And look at this, look at the crystal appearance. It's hexagon shaped, okay, and weakly radio opaque. So how do you diagnose it? Like, first, what is the first thing to do? KUB. It's good for radio opaque, like calcium oxalate and calcium phosphate. We already said 75% calcium oxalate. So, of course, you have to do KUB first. But look at the sensitivity and specificity, my friend. 45 to 59%, specificity is 71 to 77%. So you can miss a lot of things, right? So let's look at the other, like ultrasound, right? Again, sensitivity kind of goes up 45, 88% for renal stones, and urethral stones sensitivity is like 45 to 88%. Still not very good. So what's the best test? Non-contrast CT scan, okay? Don't order regular CT scan. It has to be like, non-contrast, that's the word. Look at the sensitivity and specificity, 94 to 97%, specificity 96 to 100%. So that is the best test to pick up. Remember that, okay? Pregnancy, during pregnancy, only do ultrasound. Don't radiate the baby, okay? And then how do you treat a small kidney stones? You can pass through urinary tract without treatment. You can give alpha blockers so you kind of help in the expulsion therapy, okay? So mainly in the distal urethral stone, you can use that. Like large kidney stones, then you have to do like urgent treatment and all that. Pain management, hydromorphine. I mean, a combination of IV morphine and ketorolac is more effective, but you can use hydromorphine, tramadol, and those are the choice. And alpha blockers for medical expulsion therapy with the distal urethral stones, that's mainly. So tamilsocin, you got aflosocin, you got silodosin and doxycycline, that you could use it, okay? Kidney stone removal, mainly shockwave lithotripsy is the most common. Break it down to small part. Then you got cystoscopy, ureteroscopy, you got percutaneous nephrolithotripsy. Okay, now let's look at the indication. In extracorporeal shockwave lithotripsy, it's like, your renal stone less than 2 centimeter and uretral stone like less than 1 centimeter, you can do lithotripsy. And ureteroscopy, if it is uretral stone, you have to do ureteroscopy, okay? And if it is ureterorenoscopy, when the renal stone is like less than 2 centimeter, and then you do percutaneous lithotomy, renal stone greater than 2 centimeter, and the proximal uretral stone like greater than 1 centimeter. It's good to know the numbers in that. Now, if it is symptomatic, like how do you like uretral stone? Like first you have to, if it is urosepsis, it's complete obstruction, renal failure, what is the first thing? Urgent call to urologist. If it is less than 10 millimeter, you can do the alpha blockers, strain, hydration, and the pain control. But if it is greater than 10 millimeter, again, urology consult and intervention has to be done. Management of infection, this is complicated UTI, my friends, so make sure you treat with a good antibiotic and treat the patient, don't miss it. Now, pregnancy treatment is a little bit different. Pain control with paracetamol or Tylenol, and conservative management. If you cannot do conservative management, you can do the ureteroscopic stone removal. What are the contraindication? You got, percutaneous lithotomy is generally contraindicated, and shockwave lithotripsy is absolutely contraindicated. Sometimes it's good to know, like in the management of pregnancy, it's like very important to know. Transplanted kidney, you can do shockwave lithotripsy, flexible ureterorenoscopy, or percutaneous lithotomy is preferred. People with hyperparathyroidism, everybody know you have to do parathyroidectomy, right? Prevention, drink a lot of fluids, increase fruits, vegetables, avoid excessive animal protein diets, avoid excessive salt, avoid excessive vitamin C, vitamin D consumption, and consume phytate-rich food, reduce consumption of oxalate-rich food, and take calcium supplement with the meals. So the prevention, like potassium citrate for calcium stones, uric acid, allopurinol, and steroid stone, antibiotic, and cysteine salt, metacarpopropional glycine, and potassium citrate. And the complications are usually ureteral obstruction, ureteral stricture, infection, renal failure are the major complications. And thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Thank you.